Our next speaker is Dr. Laura Schanberg, who will discuss. Oh, we're reversing them?
Yes, she's
Hold
a second.
on.
No, she's a second one.
Sorry, 1 second.
Cardiovascular disease in pediatrics.
No, oh, okay, sorry. Sorry about that, we didn't rehearse properly. We'll talk about cardiovascular disease in pediatric systemic lupus. Dr. Schanberg is professor and co-chief of the Division of Pediatric Rheumatology at Duke University Medical School and chair-elect for CARA, which is an enormous organization in the United States and abroad, Childhood Arthritis and Rheumatology Research Alliance. And I'd also just like to point out that she was the principal investigator of a seminal NIH study, atherosclerosis prevention in pediatric lupus, otherwise coined as the APPLE trial. We welcome Dr. Laura Schanberg.
Thank you very much for the opportunity to speak today. Let's see. My disclosures, Pfizer provided study drug for the APPLE trial, which we will discuss briefly today, and then some consulting. So the objectives of my talk today are to identify cardiovascular outcomes and outcome measures in pediatric SLE, highlight the role of inflammation in cardiovascular events in SLE, and discuss strategies for interventions that may reduce the risk of future cardiovascular events in children, well, once they become adults. So I would like to bring this sort of into the real world by talking about a patient. And this is Nicole, who was diagnosed with lupus at age 13 years and then presented to her med-peds rheumatologist at 25 years of age. She had a malar rash, arthritis, Raynaud's, pretty standard, clearly had lupus, positive autoantibodies, negative anticardiolipins. She had a history of hypertension and osteopenia and was currently being treated with hydroxychloroquine, azathioprine, prednisone, calcium, vitamin D, hydrochlorothiazide, and oral contraceptives, but she was poorly compliant with her medications. She was married but didn't have children, worked full-time, smoked half a pack a day of cigarettes. She had family history notable for a paternal grandfather who died of an MI at 61 years, as well as some lupus and diabetes in her family. So she presented to, at age 25, she presented to the clinic with subacute dyspnea on exertion. Her exam showed sinus tachycardia, a mild rash, arthritis. Her labs showed a low complement, C3 and C4. She was anemic. Her anti-double-stranded DNA antibodies were high. Her SED rate was high, and her CRP was elevated as well. Her ECG showed new ST changes in anterolateral leads. Her echo showed a decreased left ventricular ejection fraction of 35%. And her cardiac MR showed delayed enhancement in LAD distribution. She was cathed, and as the picture shows, she had 80% LAD occlusion. So the discussion at the time was whether she had vasculitis of her coronary arteries or whether she had atherosclerosis causing an MI, or both. Her vessel was not stented. She was treated medically with aspirin, warfarin, lisinopril, furosemide, Carvedal, started on atorvastatin, treated for the active lupus that she had with prednisone and mycophenolate, but she declined cyclophosphamide. She was encouraged to stop smoking, and her oral contraceptives were discontinued. So this is a slide that everybody has seen before, and the point is just that we are doing better at keeping lupus patients alive than we used to. However, what that means now is that we need to really concentrate on more late effects, and most of us are probably familiar with this bimodal mortality pattern of lupus, where early on our patients die of lupus flares and or infection, but late they're now dying of cardiovascular disease, which brings us to the topic for this talk today, but also serves as the reason for the emphasis at this whole session, not just this session, but at the entire meeting, that there's a lot of discussion about cardiovascular disease. What's particularly striking about the cardiovascular disease in lupus is that it really affects a group that should be extremely low risk. So premenopausal women should really have almost no risk of MI, and instead, those of our patients with lupus at all age groups have a much higher rate of myocardial infarction and angina. And this graph, this table is from Sue Manzi's paper way back in 1997, but points that out very well. But children are not little adults, and those of you in the audience, it's hard to know how many are pediatricians and how many are adult people out there. So how many pediatric rheumatologists are out there? Okay, so there are a lot of adult people too, okay, who may need to be reminded that children are not little adults. And pediatric onset SLE is more severe than that in adults, with higher disease severity at presentation, more organ system involvement, more organ system damage, and higher mortality than in adults. There are higher SLIC scores seen, and nephritis, malar rash, lymphadenopathy, and chorea are all increased in pediatric SLE compared to adult. But of particular importance for this talk is the extensive burden of disease exposure that these patients get. So if you get lupus when you're 50, you only have to worry about the side effects of it for 20 or 30 years. But if you get it when you're 10, you have a very long time to get complications of disease, of severe disease, as well as side effects from the medications. In addition, the psychosocial challenges are different. We certainly think that our teenagers are less good at taking their medicines than the adults are, as well as immunologic differences. And we really don't yet understand how the maturing immune system impacts lupus or is affected by medications or may impact cardiovascular disease. So the mechanisms of atherosclerosis at all ages are mechanical, hypertension, shear stress, lipids, injury repair balance of endothelial progenitor cells, endocrine elements like insulin resistance, and of course inflammation like we see in lupus. And this is sort of a really yucky picture showing a lot of cholesterol in a vessel. But lupus is really a perfect storm for cardiovascular disease, with both standard risk factors and SLE-related specific risk factors. And so we're all aware, even those of us in pediatrics, about the traditional risk factors: age, hypertension, hyperlipidemia, hyperglycemia, smoking, genetic factors. But then there are the whole array of lupus-related risk factors, and the more you read about the lupus-related risk factors, the larger the list becomes. This list includes systemic inflammation, autoantibodies to endothelium, HDL and phospholipids, circulating immune complexes, activated complement products, nephritis, and dyslipidemia. But actually, this is yet a larger picture of what makes lupus a perfect storm, and there are some additional things shown in this slide, and in particular, I'd like to concentrate on the role of medications as well. So which of these things are very apparent in children? We know that there are increased rates of dyslipidemia in children with lupus. There are increased rates of hypertension in children with lupus. They have decreased flow-mediated dilatation and increased carotid intima-medial thickening. Not all of the other lupus-specific risk factors have been demonstrated yet in pediatrics, but I tend to assume more that they are present than that they're not. but this list shows risk factors that we have identified in kids. So why should we worry about CVD in children with lupus? Because in fact, as the sample patient that I described, they may have been diagnosed with lupus in the pediatric age group, but most of them don't actually have their cardiovascular events until they're in the hands of the adult rheumatologists. However, we know that atherosclerosis, even in children without lupus, begins in childhood, and the picture shows a fatty streak in the aorta of a 10-year-old trauma victim. So this is, these streaks are in a child who does not have lupus. So it's sort of, I always hate looking at this and thinking about my son and knowing he probably has these streaks already in there. And then when I see him go to McDonald's as often as he does, that makes me worry even more. As I already mentioned, children have a long burden of disease and medication exposure. So if the lupus perfect storm is pushing them towards cardiovascular disease, they're going to have a much longer time to be exposed to that. There are some premature cardiovascular events that do happen in childhood. Families and patients are often unaware of this risk because nobody thinks about their 12-year-old or even their 17-year-old being at risk for cardiovascular disease. And actually, it's not just the families and the patients that don't think about it, but oftentimes the doctors don't think about it. Because when they show up in the ED with heart pain, even at age of 25, and that particular girl that I presented showed up at the Duke University ED, it wasn't until much later that they thought about the fact that she might be having a heart attack and that maybe her lupus had something to do with it. So they're unaware of the risk, which probably increases the risk, and most prevention efforts don't begin until adulthood, which is a real lost opportunity. And that if we can start looking into this and treating them when they're younger, perhaps we can prevent the premature atherosclerosis. So this is just a timeline of atherosclerosis, and I show this only to point out, and this is in healthy people, and this is just to point out that from the first decade, endothelial dysfunction starts to occur, and there are changes, including lipid accumulation, that are happening really early, even in normals. So again, thinking about this in children with SLE, they're not born with atherosclerosis. However, there is a gradual and silent buildup over time through childhood into the teen years and young adults. And then they generally have an acute event, an MI or a stroke, as middle age or really young middle age. I don't really think of a 25-year-old as middle-aged. I still like to think of myself as middle-aged. But they have an acute event. And then we start thinking about prevention to try to delay progression. But by that time, they're really far down in the process. And again, that event usually happens under the care of adult providers, rheumatologists, and then they end up at a cardiologist. But the problem begins much earlier. It begins when they're in the pediatrician's hands, not the adult rheumatologist's hands. So how do we detect subclinical atherosclerosis? Which is the only way we're going to be able to identify this in the kids that we take care of. So there's thinking about risk factors for sure, imaging and biomarkers. Now, this is just a list of different cardiovascular outcome measures. The STARD procedures are commonly used in clinical trials, including intimamedial thickening measurements, CT coronary calcium, carotid plaque, flow-mediated dilatation, and C-reactive protein. Now, these things all have pluses and minuses. And in the scope of what can measure subclinical atherosclerosis earliest, the flow-mediated dilatation is the earliest measure of early atherosclerosis. And then there are problems with FMD. It's very user sensitive. Whoever is actually doing the procedure, there's a lot of variation. Children actually don't always care for the procedure, even though it's just using a blood pressure cuff. And the CIMT is the next thing I've shown up here, and the picture just shows how IMT is measured, and it's pretty amazing, but you can measure this little tiny area in there, which is just usually a few millimeters, and actually detect changes over time, which seems pretty incredible. Then there's the carotid plaque and coronary calcium quantification, but the problem with that is that it doesn't work in kids at all because they don't have plaque and they don't have coronary calcium. So that's not on our list of ways to identify subclinical atherosclerosis in kids. Do medications influence this atherosclerotic risk? Well, we think probably, but actually none of the cardiovascular outcomes have been included in adult or pediatric treatment RCTs. So the data is all from retrospective cohorts, and as we all need to remind ourselves often, is that association does not equal causation, and all we have is information of the association type. So summarizing, this table just summarizes the presumed or associated impact of medications, of various medications. Steroids, as we all know, are atherogenic and promote metabolic syndrome, so they are potentially negative impact on cardiovascular disease. Hydroxychloroquine probably helps and is used independently to treat lipids. Azathioprine, interestingly, seems to be pro-atherogenic according to a couple of studies. One is the Apple trial, and in the Lumina trial, mycophenolate may be helpful. Methotrexate, what we know, is really plus minus. It's unclear. Same with glufonamide. And rituximab may decrease atherogenicity, but again, these are all associations and not really strong data. I wanted to just spend an extra slide to just talk about glucocorticoids. In the Apple trial, it was interesting that moderate dose prednisone seemed to be associated with lower IMT measurements, but the very lowest and highest doses of prednisone were associated with increased CIMT. And our thought is that it may be that a little bit more steroids and a more aggressive immunosuppression will cause less carotid thickening, whereas if you use too much steroids, then the pro-atherogenic impact of the prednisone outweighs any potential benefits. And this is just a graph showing IMT measurement this way and prednisone dose this way, and you can see that there's sort of a little jag to this curve. So what can we do for children now? And we certainly encourage using following the primary prevention recommendations for children and adolescents of all children and adolescents. And that includes a low-fat diet for children greater than 2 years of age, keeping their cholesterol intake at less than 300 milligrams per day, selective cholesterol screening if there's a family history, and if there is an LDL that's greater than 130 milligrams per deciliter, recommending dietary intervention for at least 6 to 12 months. Cholesterol lowering therapies for an LDL greater than 190, or an LDL greater than 160 with 2 or more risk factors, with a goal LDL of less than 130, ideal LDL less than 110. Now, what's hard to know, and then there are other guidelines as well, including blood pressure screening. All children over the years of 3 should get blood pressure screening. And keep in mind that children's blood pressures are judged to be normal or abnormal based on comparisons to age-matched controls. There are tables around about that. So 120 over 70 is okay for a 20-year-old, but it's really bad for a 3-year-old. Daily exercise, 60 minutes of moderate to vigorous activity a day, and to achieve and maintain a normal BMI. However, it's not clear that these guidelines are sufficient for children with SLE. Clearly, they are a beginning and are a minimum of what should be followed. So going back to Nicole, so what can be done to prevent atherosclerosis-related cardiovascular morbidity in children and adults with lupus? Well, obviously managing risk factors like managing hypertension, detecting and treating dyslipidemia, controlling disease activity, limiting steroid exposure, and stopping smoking. But what about statins? And I think this continues to be a question. There's always been interest in statins because it's so effective in the non-lupus population, in the normal healthy population at preventing events, cardiovascular events. They are known to have pleiotropic anti-inflammatory effects. They reduce high-resolution CRPs. They increase numbers of endothelial progenitor cells. Statins reduce leukocyte cytokine release and reduce the production of reactive oxygen species, all of which theoretically should improve cardiovascular disease. There's also been study TERRA, reducing disease activity in RA, and statin withdrawal in RA has been linked to MIs. So it was a lot of interest around the idea of whether we could use statins to try to prevent premature atherosclerosis in children with lupus. And this was from the Apple study. The final paper was just published in 2012 in Arthritis and Rheumatism. We enrolled 221 children between the ages of 10 and 21 with 3 years of follow-up. They received standard therapy of hydroxychloroquine, aspirin, folate, a special low-fat diet, and then were randomized to either placebo or atorvastatin, and this was on top of the standard therapy for lupus that their local physician would be using. The primary endpoints were was the progression of carotid IMT. The mean age of the patients were just under 16. Most of them were non-white. They had a low SLEDAI of 4.7. Their baseline LDL on average was 86, and their CRP was 3.6. What we saw in the Apple trial, which didn't meet its specified endpoint, was that the progression, let's go back one. That the zero line here, let's see. Sorry, I've gotten myself a little turned around. Over 3 years, wait a second. I got myself turned around because I was on the wrong slide. Okay, I thought I was looking at the results. Okay, so what the Apple results showed was that we measured IMT in 12 different ways, and what we saw was that most of the different types of measurements cross zero, suggesting that there was, in fact, no benefit. However, still most of the, many of the different measurements are certainly well over to the left in their means. what we clearly showed was that the placebos patients progressed over 3 years. And this is of particular interest because normal patients of the same age should not show IMT progression at this particular age. And in fact, patients with familial hypercholesterolemia only progress at the rate represented by this line here. So patients with lupus, CIMT measurements are progressing at a rate that's greater than patients with familial hypercholesterolemia, which certainly gives us another impetus about why we should be taking care of these patients. Not surprisingly, secondary cardiovascular endpoints, the CRP went down, the cholesterol went down, the LDL cholesterol went down, but HDL and triglycerides were not impacted, as is expected for statins. We've recently done a secondary subgroup analysis, which is just in press and annals right now. And what we did in this was look at different subgroups to see if there were groups of lupus patients that might benefit from early treatment. And what we saw is that age, BMI, duration of lupus, baseline lipid measures, cumulative prednisone dose, and cumulative SLEDAI did not did not show any differences in treatment effect between the groups. On the other hand, patients with an elevated CRP did show a difference, as well as children who were post-pubertal, and that was defined as a Tanner stage greater than or equal to 4. And if you put the pubertal and CRP values together, there seemed to be a group of patients that did benefit from treatment with statins. So what's next? Perhaps we should be using statins in some children with SLE. The question of niacin and its ability to decrease LPA levels is also of interest, despite recent studies that suggest that statins and niacin don't help in healthy folks. Aspirin, ACE inhibitors, what's the role of vitamin D, as well as exercise. And there may also be non-atherosclerotic mechanisms of cardiovascular disease that are active in lupus, and this is from a preliminary study that Stacey Arduin is doing at Ohio State, and what she's showing is that in lupus patients, there is an increased non-ischemic cardiomyopathy present, shown here by increases in the T2 signal on cardiac MRI, which is apparent during an SLE flare, which is shown here with all the highlight, and that this was present despite normal echo, normal CK, and a normal troponin. And then with treatment, has resolved. So in summary, and this just leads to more areas for research without any assumptions to be made about that right now. In summary, accelerated atherosclerosis is a complication of pediatric SLE. Inflammation plays a critical role in atherosclerosis, and control of disease activity may reduce cardiovascular risk. Optimal measures for defining subclinical atherosclerosis are not yet defined or clinically available in children. More data is needed concerning the long-term cardiovascular impact of medications, both in adults and children. And while there's no evidence-based mandate for routine use of statins in children and adolescents with lupus, post hoc analysis of the APPLE trial suggests particular subpopulations, that is, patients with high CRP who are post-pubertal may benefit from treatment. We also do need to address within the pediatric doctor's office primary prevention in children and adolescents with lupus, both their hypertension, lipids, obesity, and physical activity. And I'd like to thank collaborators Stacy Ardwin, Christy Sandborg, Kelly Miskowski, as well as folks at the DCRI and Wake Forest and our funders, as well as all of the Apple researchers, many of whom I've had the privilege of seeing here, and of course, to our patients. Thank you.
Open for questions. So I have a million questions for you.
A million?
So maybe I missed it, but can you address hydroxychloroquine and, interestingly, too, the dose you use and whether there might be some avenue open for the consideration of measuring levels of hydroxychloroquine?
You know, we used a dose between 6 and 7 milligrams per kilo for the patients that were treated in the Apple study. We used that as, you know, baseline therapy for everybody, so we didn't obtain any data about whether they would have done even worse without it. However, it's clear that Plaquenil by itself is not sufficient because over 90% of the patients in the Apple study were indeed taking Plaquenil. We did not make any attempt to measure it, and I really don't know anything about the measurement of hydroxychloroquine. I don't know if anybody else does.
Yeah, Natalie Costadillo at Chamelo has written a lot about it, and we could discuss that offline, but it could be interesting to evaluate that.
And we do have, we have information, you know, we have serum that's still banked, which actually is open for people to use, and could go back and look at that.
Thank you. Yes?
Thank you very much.
If you could identify yourself.
Yeah, my name is Dr. Tullis, a pediatric nephrologist actually from London. Thank you very much for your interesting presentation. When you see the lack of response to statins in a situation like this, you always think that there is sort of an overriding factor that you can't get over with the treatment with statins. We see that in chronic kidney disease, for example. And that one would, of course, be ongoing inflammation. And how much did you make sure that you had pushed the inflammation in these kids as far down as you could before you included them in the study? And were you able to sort of stratify them or to later analyze them according to different measures for inflammation?
So we did not make any attempt to do that when they were enrolled in the study. All comers were enrolled as long as they didn't have a creatinine over 2.5 and have active liver failure or cholesterols over 350 to begin with. When we stratified them by disease activity using the SLEDAI, we didn't see any difference about treatment effectiveness, but we did, as I showed you, with CRP, which is also a measure of chronic inflammation as well as acute inflammation.